Dr.Sri Ganesh, who couldn't be here due to health reasons. But cataract surgery today has become a refractive procedure where all our patients expect spectacle freedom even after cataract surgery. So today we'll be talking about all the ways that we can render our cataract patients spectacle free and how to do that. We have some distinguished speakers on the panel today. We have Dr. Shreyas Ramurthy, Dr. Gaurav Luthra, Dr. Jagat Ram, Dr. Sheetal Brar, and myself, Dr. Supriya Sri Ganesh. And we will be starting with the first thing that we do for our cataract patients, which is biometry. And an overview of the biometry devices that we have will be given by Dr. Shreyas, who is from the Eye Foundation, heading Eye Foundation, and who's a young and dynamic speaker who's doing excellently in cataract and refractive surgery. Over to you.
Thank you so much, Dr. Supriya, for having me over, and thank Sri Ganesh sir also for always including me in this session. And it's unfortunate that he couldn't be here today, but we wish him well. So today I will be running through the overview of biometry devices, the kind of devices which are available to us, what it offers additionally, and how we can choose. So to very start with, I mean, we broadly have these ultrasound biometry devices which have always been there. Most of us have moved on to optical biometry, and even in optical biometry, we now have a combination of topographers and tomographers which are able to add to the biometry data itself. If we start with ultrasound, I think it still has a role to play in today's day and age. It is still not a tool we can do away with. Yes, no longer should we be practicing contact biometry, but definitely immersion, if done properly, can give excellent results and has been shown to be within a 0.1 millimeter of optical biometry when it is done by a safe and repeatable biometrist. Getting a good high quality A-scan with the right spikes is important. Looking at slightly adjusting the gains, higher gain for better sensitivity, lower gain when you need better resolution, denser cataracts increasing the gain, decreasing when we have artifacts like with silicone oil. Using all these small tips, we can improve our outcomes and efficiency even with ultrasound biometry and get excellent results. However, there are some situations where there may be some limitations, especially when you have a highly myopic eye, where the visual axis and the anatomical axis may not match, because in a staphylomatous eye, the anatomical axis is a little more posterior than the visual axis, and this may be a little bit of a challenge. Whereas with optical, because we are depending on patient fixation, it still gives us accurate measurement at the fovea. And this is one of the main advantages that why you would probably want to move into an optical biometer. So let us break it down into various components of biometry and how each of the devices compare. We'll start off with keratometry, which is possibly the most important variable as far as deciding or optimizing our outcomes with cataract surgery is concerned. A manual or auto ref can give a fair initial idea before you start with anything, before you even look at the cataract, to actually have this data, because ideally this should be done as the first test before anything else has been, even a dilating drop has been put in the eye, because only if you get an accurate measurement, repeatable measurement with this, will you be able to go forward with accurate calculations. There is excellent agreement between all the devices, any type of optical biometer that you may consider, whatever has been published in literature. Tomography is also useful, especially in post-LASIK patients. All the major tomographers, Pentacam, Galilei, Sirius, all give repeatable values. However, all our regression formulae are based on central data. And that is why we still prefer the keratometry taken from biometry devices rather than from tomographers from the SIMK values, which gives us a more average over a larger area of the exposed measured cornea. While this may be accurate in the keratometry itself, it's not directly applicable into the formulae. Looking at specific devices, like I said, generally they focus between the 2 to 3 millimeter area depending on the device that you're using. The number of points may vary, but it's this 2 to 3 millimeter area which is most important, which is what all our formulae are designed for. Additionally, a concept like the telecentric keratometry, especially in IOL Master, really helps, because even if the patient is not a little cooperative or your biometrist is not as talented, it ensures that the spot spacing is kept the same irrespective of the device to eye distance. So this is very important because even if the patient is moving their head a little bit or is not rested completely, you still are measuring over the same region in the cornea and you get more repeatable values. That's one very important concept with telecentric. Going further, we have this total keratometry concept where essentially we all understand the importance of measuring the posterior cornea, especially for toric IOL calculations. And the total keratometry, it gives us a toric model where it measures the central 3 mm cornea and also gives us the posterior torus fit. That is, it measures the posterior points directly on the from the posterior surface of the cornea. And while we did already have devices which could look at the posterior corneal power and posterior corneal astigmatism, it did not give us a symmetric measurement between the anterior and posterior. This is really important because then we can now devise formulae based on this total keratometry, and these total keratometry formulae are ULIP compatible, and so you don't really have to change clinical routines to measure it. Like I said, while Pentacam and Galilei gave posterior corneal astigmatism, they were found to be less effective than the assumed values which we got in the Baylor or Barrett nomograms. The mathematically derived values were better than the actual measurements which we got from Pentacam and Galilei because essentially the formulae were not designed for these devices. So that is where the biometric devices which measure the central 3 mm, give us the posterior torus fit and give us formulae which are applicable for this have a greater edge over the tomographic devices, and that is where the Barrett TK formula, Barrett TK toric have become a very useful device and have improved refractive outcomes significantly. It is also very useful in post-refractive surgery eyes, and the Barrett TrueK has performed better than the ASCRS average, Sharma's, Haig's L. So instead of now looking at multiple formulae, I think Sheetal will be talking about post-laser refractive surgery eyes, but it has actually oversimplified the entire thing by saying that now you can just look at the TrueK, Barrett TrueK TK, and that is really a one-stop solution for post-laser, post-refractive surgery eyes. And just to show that TK doesn't work just with one particular formula, even if you apply it to another formula like the Haig's TK, it still performs better than the regular Haig's L or the regular Barrett TrueK without taking in the total keratometry. So as a concept, it works, and it works even with different formulae. Additionally, you also have the angle alpha and angle kappa measurements, which are also very useful, especially when you're looking at premium IOL surgery. Going on to anterior chamber depth measurements, this is very important, especially where most of the 4th and 5th generation formulae look at deriving the effective lens position as a very key indicator for outcomes. So measuring an accurate anterior chamber depth and accurate lens thickness becomes very important in getting the ELP. So the IL Master 500 measures from the epithelium, and also it was not very repeatable when it came to pseudophakic eyes. The measurements were not so accurate, but the other Scheimpflug devices were very good. IL Master 700, it has corrected that, and any of the swept source based biometry devices really give us a greater advantage because you have a direct foveal imaging which is now available. By directly measuring, looking at the fovea, we can tell whether the patient is fixating at the right point or not, and this is really improved in getting repeatable values. When you know that the patient is fixating correctly, your axial length and keratometry measurements are similar, and you also get a very similar and repeatable IOL power calculation. Whereas in this particular image, you can see that the foveal pit has not been imaged correctly, and this leads to a significant difference in the keratometry. And even though if it's just a 0.5 diopter difference and a 190 micron difference in axial length, it gives more than a diopter of difference when it comes to IOL power calculations. So it's very important that we ensure that the patient is fixating, and now we have a device which is actually telling us whether the patient is fixating properly or not. Like I already mentioned, because we are able to get better anterior chamber depth and better lens thickness values with the B-scan biometry, we are able to get a greater and more effective lens position mapping. We can also look at subtle macular pathologies which can ensure that before the patient is being counseled, when you have this image, you know that they are probably not eligible for premium IOLs. You can even investigate further, get a retinal OCT done. And I'm not saying this is a replacement for retinal OCT, but it just gives you an idea before you subject the patient to other things. Again, the penetration with the OCT-based systems, OCT-based biometry devices is better, and even through denser cataracts, through dense posterior subcapsular cataracts, we get very repeatable values. Combining biometry with tomography, now we have a host of devices which are available, from the Antirion, the Lensa LS900, Aladdin, the IOLMaster 700. We have devices which are basically biometers, which are giving us a topographic measurement. We also have standard Scheimpflug devices like the Galilee, the Pentacam, all of which are now also coming in, which are compatible with axial length measurements. So, and like the G6 from Galilee and the Pentacam AXL also gives extremely accurate values. So how do they compare? By when studies which have looked at comparing the results, biometry results from tomographers and biometers separately, have shown that they give us comparable IOL power measurements and comparable results itself. The Antirion has gone a step further, where you actually have excellent OCT-based topographic values, which are similar to that of what we can get with the Pentacam or the Galilee. The measurements, the anterior axial, posterior axial curvatures, the epithelial thickness maps, elevation maps are extremely good. You also get the ectasia indices, which are unique to this device, but again, very useful even for screening early grades of keratoconus. Within the same device, you also have various formulae which can be entered, and various IOL, different types of IOLs which can be entered, and you get the accurate biometry data. You have the toric IOL power calculations, which is already built in, which has the Barrett toric calculator and the Barrett Universal 2. So, and it also gives us an excellent anterior segment OCT. So it really has become a one-stop solution for topography, biometry, ASOCT in all ways, where you would have to use 3 separate devices all rolled into one, and also helps us in other measurements like the phakic IOL, the white to white, and even imaging the exact angle measurements, the scleral spur. All of these have become extremely useful. The other devices, like I already mentioned, do provide some data. However, they are all more of Placido-based devices and are not really a replacement for a tomographic device. The Topcon gives it as well. You get it from the Lenstar and from the IOLMaster 700. But these are all rudimentary images and don't really replace a topographer itself. However, having the Barrett toric calculator or the Barrett TK toric calculator helps us in ensuring that every patient comes up with a toric calculation and you know whether to use this or not. So with this excellent array of imaging systems that we have today and the 5th generation IOL power formulae, Emmetropia for all patients has become a real possibility. Thank you so much for your attention. Thank you.
Thank you, Dr. Shreyas, for that insightful talk about the array of biometers that we have. If there was one that you would choose, which would that be? Just for your practice.
No financial interest. They've not really given us any discount, but if I wanted to choose one today, it's the Antirion, because it really gives a one-stop solution for everything. Between Antirion, Argos and IOLMaster 700, which we are using right now, I feel we are getting extremely good value from money from that device.
Thank you so much. I'd like to call upon our next speaker, Dr. Gaurav Luthra.
Oh, I have a question for Shreyas, because I'm using the Antirion 2 and for about a year now. I don't know if the mic is working, but you know, there have been occasional outliers. Like we do biometry on 3 devices: the 700, the Lenstar, and the the Antirion. And especially for toric calculations, I found the axial length is a no-brainer, but the Antirion does anterior and posterior corneal measurements as well, and incorporates and gives you something like a true K kind of a thing, right? So the thing is that the two things don't match, the 700 and this, and the explanation given was that the tear film plays a role, and the Antirion kind of does away with the tear film because it's OCT based as compared to the 700. 700's Ks are more like measured from the, at least the anterior Ks are measured not from the OCT but from the, from those same number of points that were used in the 500,
Yes, sir. The
right?
keratometric measurements is still the telecentric,
Right.
whereas the TK value comes from the posterior torus fit, which is
Whereas
SSOCT based.
The Antirion does both the measurements from OCT,
Yes,
the
sir.
anterior and the posterior. So they are, sometimes different. So how do you decide if you're noticing a difference in the anterior, the true K values from the 700, and which one will you trust? Sometimes the IOL is off by half to 1 diopter.
We
even
did a
toric
study, sir.
calculations
We looked at especially these 2 devices first, IOLMaster 700 and the Antirion, and it was quite repeatable. The only thing is with the Antirion, you need to use that software, which they give you 2 logins, and you can use the login to input the data and do it. But apart from that, with regards to the measurements, we didn't really have to do to get two different toric models between two different devices. That almost never happened. So that was a good experience that we had, and even published literature suggests that it is quite repeatable. So initially we were doing with both devices for all patients till we were comfortable. Now we just do any one based on where the patient goes.
So in our practice, we use the IOL 700 routinely and use the Barrett suite and we get excellent results. And as an all-in-one for topography and other things as well, we do have, as a refractive practice, we do have MS39 and other things which takes care of it. So that way, the IOL 700 works very well for us.
Yes. Like I said, IOL 700 is still, as for a biometry, is excellent device. There's absolutely no problem. But the corneal topography which it gives is very rudimentary, and the CT version is, all those who have the CT version of the IOL 700 it's not really adding too much value.
It's a good screening tool.
So it's just,
tool.
even as a screening tool, it's only if it's grossly abnormal are you going to detect anything in it. And that's where the OCT based anterion and works better.
Thank you so much. I would like to introduce our next speaker, Dr. Gaurav Luthra, who really needs no introduction. He's been a pioneer in cataract refractive surgery in India. And today, sir will be talking about IOL formulae, which one and when.
Thank you, Dr. Supriya, for making me a part of this course. And we are missing Sri Ganesh also. He's not attending the AS for some reason. And very good afternoon to all of you. Good evening, actually. So my topic here is to talk about which IOL formulas to use when. And if we trace history, the first generation formulas, this is where we started out in the beginning, and then going on to the second generation formulas which were popular when I was studying, and then we came up to the SRKT. We used to use the SRK2 formula at the time when I was trying to do, and we had the single biometer which was made, the Humphreys biometer, which was available, and there was little else that was available at that time. And we've come a long way. I mean, when we talk about all these methods of biometry today, and we try to bring ourselves closer and closer to that holy grail of 0.25 or 0.5 plus minus for 90% of our patients. Then the fourth generation formulas, which have again raised the bar, and then today lots of newer formulas. We have the Barrett's Universal 2, of course, the Hill RBF3, the Super Ladas, the Kane, the EVO, and of course some even newer formulas which are now becoming available to us. And some of the online calculators, the ASCRS, the ESCRS calculator has come up in a very big way, and it can give you 4 or 5 different formulas on one screen, and you can choose what you would like to choose. So there's lots of exciting stuff which is happening, and this is how they stack up, the formulas. And you can see that for the short and normal and long eyes, we used to have this as a much shorter graph, and now if you look at the bottom of this thing, you'll see that the Olsen C, which is a ray tracing formula, the Barrett's 2, which is a Virgin's formula, and the Hill RBF, which is the Hill RBF3 now, which is the artificial intelligence formula. They seem to be doing great from the short to the medium to the very long eyes, and you can see that you don't have to do much. If you have to get 95% of your eyes through, you'll probably choose the Barrett's or the Hill RBF, and some people would like to use the Kane formula as well today, especially for some special situations. So looking back, the SRKT, which is still a great formula, if you have an eye where you don't have optical biometry possible, and you can't get the axial length, and you're going to use the immersion scan, I would still think that SRKT is still a very, very predictable formula. And these can be used for eyes, the SRKT can be used for more than 26 millimeter eyes. So and you can of course use a combination of the Hoffer Q, the Holiday 1, and the SRKT for eyes between 22 and 24.5. And of course, again, the SRK 1 and 2 are obsolete and should not be used by anyone if you're still using that. Hoffer Q remains a good formula for short eyes, and for especially pediatric eyes, it has been used for many years, and it has stood the test of time. So eyes shorter than 22 millimeters are the ones where you could be using the Hoffer Q. Holiday 2 has remained a favorite for many people, and today, while it may not be a great formula to use, but there are the the short to the long, very long eyes for which you can use, but you have to use the Wong-Kok adjustment because when you use the low plus to the minus power range, then the Wong-Kok adjustment for those very long eyes has to be used along with the Holiday 2. The Olsen C, for some reason, was never very popular in my practice. We tried using the Olsen C. It utilizes a concept called the C constant, which is basically a fraction of the lens thickness by which the center of the eye will locate itself post-op. So basically plays with ELP, and this is a personalized kind of a constant that it has. And this is something, and Olsen C is a ray tracing formula, has been supposed to be one of the most accurate ones, but in spite of repeatedly trying for some reason, and maybe after my talk is over, we can ask the other panelists what is their take on the Olsen C. I was part of the Hill RBF study. We were one of the beta testing sites for the Hill RBF formula and for Warren Hill, and the first and the second formulas which came out were including some of the data from our center as well. It works on artificial intelligence and the RBF radial basis function. And when Hill RBF came out, it was quite an amazing thing because it did not depend upon the ELP, but rather on artificial intelligence. And it was good because it would tell you those eyes which were, where the measurement was reliable, and it would also tell you where eyes which were out of bounds. So you could not use you could use it with like caution. And this was one of the only formulas which actually told you whether the prediction is going to be reliable or not. None of the other formulas actually tells you that. But as Hill RBF evolved in 2018, they came out with the Hill RBF 2, which was having a much bigger database, and it was more robust because it was also doing eyes from -5 to +40. And they had now almost 12,419 eyes in the database for the artificial intelligence to work better. And there were very much fewer out-of-bound eyes, and it was possible to aim for residual refractive errors, and it came with the integrated Abulafia-Koch toric calculator as well. And this was part of the LensStar only, because the Warren Hill's formula is either available online or it was part of the LensStar, which is a Hugstrite machine, because Hugstrite funded this study. So after that, today we have the Hill RBF 3, which is even more robust, and it can do calculations for biconvex IOLs from +34 to +6, and for the meniscus design IOLs from +5 to -5. And it is also now having more variables. When it started out, it had only 3 variables, and now it can actually take 8 variables, which makes it even more reliable and more predictable. If you can add more variables to it, it will give you more data, which includes the lens thickness, the white to white, the central corneal thickness, and the gender as well. So, and it was found that gender could be an influencing factor for ILPAs, which is quite amazing. And if any of the additional 4 variables out of the 8 are not entered, the calculation will still be done, but it will have less predictable values as compared to when you use all the 8 variables. And so now it's even more robust, and frankly, even for short eyes now, it has a much, much bigger database, so it is very predictive for short eyes as well. And of course, the gold standard that we've been all so used to now with all the optical biometers, it's very important for us to understand that the Barrett's has to be used with optical biometers. And if we try to use the Barrett's suite with the measurements which are not taking for the optical, you have to make adjustments, which I'll talk about. And the Barrett suite includes 3 formulas, the Barrett Universal 2 for all the non-toric IOLs, the Barrett Toric, and the Barrett's True K, which is all for the non-torics after laser vision correction. Now there is also a Barrett's True K, Total K, TK formula for the post-refractive surgery eyes. And it, of course, it uses it does not measure, for this particular formula, it does not measure the posterior surface, but it uses a nomogram, which is age-based. However, the Barrett's TK, or the one which integrated with what Shreyas was talking about on the ILMaster 700, uses the TK values, and I will just tell you about that. So it's a Vergence-based formula, the Barrett's Universal 2, and it's based on a model eye, and it contains, it will work with an A constant and lens factor, which is also used to determine the AC depth, and it is applicable to all types of eyes, as we just saw. And it can also be used for post-refractive surgery and calculations when you use the Barrett's True K. So the Barrett's suite essentially requires you to have 3 things which are compulsory: the axial length, the keratometry, and the lens factor. And then optional ones are the anterior chamber depth, the white to white, lens thickness, and the design factor. So if you would add these 4 variables, just like the Hill RBF, if you would add these 4 factors, the Barrett suite becomes much, much more accurate. So when we are doing our biometries, I think it is so important for us to realize that if we are giving more variables to the formula, our IL power prediction is going to be much, much more accurate. So let's not ignore what are the optionals. If we have measurements for those things, we should definitely include them into our calculations. This is what it looks like. And the lens factor and the design factor are now available from almost all the IL manufacturing companies, and we must make it a point. Not only that we should have them, I've realized that many of our IL companies, they actually are not great at entering this data into the optical biometers, and I've found that I use 3 machines like the LensStar and the 700 and the Anterion, and I found that they have been fed with different lens factors and design factors for the same lens. So it makes the calculations totally haywire. So you have to be very careful about ensuring that when you see the printout and you can check the lens factor and the design factor, they should be identical on all the same lens type. At least for the same lens, they should be identical, otherwise it will go totally wrong. Your measurements will not be precise. Going on to the Barrett Storic, I think I'm going to run out of time, but I'll quickly go through it. The Barrett Storic calculator, of course, I will not go into details. We are all using it. The Barrett's TrueK, I think Shreyas covered it a little bit. I came in a little late, but it offers, real-time measurements. So the Barrett's TrueK can be used for all the post-laser vision correction eyes, and it has options for hyperopic, myopic, and RK eyes as well. I do use the SCRS calculator a lot for all my post-refractive surgery eyes, especially the post-RK eyes, because it takes in data from the OCT, the optoview for the posterior cornea. It can take in data from the pentacam, from the topographer, from the optical biometer. So you have options even for the Galilei and the pentacam and other devices as well. So the more the data that you provide it has a historical data option as well. And then you get a printout something like this. If you have, for example, we have fed in, it gave me the Sharma's, it gave me the Haigis L, it also gave me the Potvin Hill pentacam measurement, then from the OCT and from the Barrett's TrueK. And then you have to see what you would like to use, and you can take a call on what would work best for you. And we do use for our post-refractive surgery eyes, especially the RK eyes, we use the EKR report from the pentacam, which becomes very useful if you look at the EKR 65 values from here. And these can be very, very useful if they are, even for toric calculations, they are very, very useful. And the TK formulas which are available on the 700, which works seamlessly on the ILMaster 700, can be very useful again for eyes which have outliers for posterior corneal astigmatism and where the nomogram will not work. And if you're going to use the ultrasonic biometry for Barrett's Universal 2, you'll have to use a customized A constant. Otherwise, it should not be used and you'll go wrong. And this can be easily done by talking to your IL manufacturers and obtaining that A constant from them. And so I would like to finish by just naming 3 formulas which are becoming more and more popular, especially in the US super LADAs. It's also an artificial intelligence formula which kind of incorporates many of the existing formulas into a single equation. And it's constantly growing because more data is being fed into it, so it improves its accuracy. And it also tries to do that. The Kane formula is very useful for keratoconus eyes. We are using the Kane formula, but also for a lot of other eyes, Kane formula is being used. It's available free online. And the EVO formula as well is again a very predictable formula for certain situations. And I will not go into details of ray tracing. I was just discussing with Shreyas. Ray tracing is available now on the MS39 and the Anterion. We are using it for some of our, so it also does toric calculation. It is good, but I still take it with a pinch of salt, and I think it's still not there to make you, it's not robust enough to kind of fit everything. So with that, I'm going to stop. Thank you so much.
Thank you, sir, for that much needed insight on biometry, which formulas we need to choose. Next, I'd like to call upon stage Dr. Jagatram. He's a very senior cataract and refractive surgeon, and sir will be talking about intraoperative aberrometry, the pros and cons of intraoperative aberrometry. Over to you, sir.
First of all, I am thankful to Dr.Sri, Ganesh and Dr. Supriya for giving me this opportunity to speak on intraoperative aberrometry. Intraoperative aberrometry, or we say opti-wave refractive analysis, ORA. It is a real-time analysis of the refractive error and aphakic lens power during cataract surgery and allow adjustment of the IOL power intraoperatively. Pros are increased accuracy in patient with myopia, increased accuracy of IOL power in patients with history of RK LASIK or PRK. Confirms the IOL power and axis alignment and shows residual refractive error and avoid toric marking. Useful in patients with high expectations and anxiety. There are some of the problems associated with intraoperative aberrometry. Not high accuracy in short eyes. It cannot be performed in patients if intraocular pressure is low. Cannot be performed if there is a central corneal opacity. Lead speculum will alter the corneal astigmatism. So patient fixation is must if it is patient is under GA. Although we have attempted in certain situation, then it is much more difficult. I will be showing some of the video clips how we can achieve, how we do this intraoperative aberrometry. Here, this is some maybe more than 5-6 year old video where continuous curvilinear capsulorhexis phacoemulsification was done here. What I want to show that after completion of the phacoemulsification, how it is done. Sufficient viscoelastic is injected into the capsular bag, and this is we have to achieve this. That then this OptiWave refractive analysis, it will show you have to catch reading. How much? So here intraoperative power calculation showed that 21 diopter of IOL to be implanted. But we have compared it because we have done in every case other optical biometry pre-operatively and compared that how much is accuracy of this system. So here we intraoperative aura was done, and then we placed multifocal toric IOL using Varion and aura as well as. Here we know that what was the power, so power was selected intraoperatively, and then comes the next video, OptiWave refractive analysis. Why? Because accuracy is important. This is a child, 8-year-old child with congenital cataract. Here also toric IOL required for this child, but we also studied it by intraoperative aberrometry. Removal of the cortex from the capsular bag, and then ultimately assessing that what will be the IOL power using aura. Adequate viscoelastic into capsular bag, and then because child was under GA, so I did some fixation part by rotation, and it showed that 27 diopter. But why we put less? Because under correction, that adjustment you have to do, particularly in children. And then, but accurately, I think it will show that how much astigmatism will be, what will be the alignment. So here it is the alignment of the axis using Callisto. But at the same time, because aura was done in this case, we know that how much will be the residual power. It shows no further rotation required, and residual astigmatism will be 0.15 diopter. This is very negligible. And probably this is the last video here, cataract surgery in post-RK eyes. We have to plan the incision, where to place the incision, so that adequate space has to be there between the two incision, where to place the side port incision, and then hematocapsulotomy and emulsification, and this is the side port incision. Main incision and side port incision, and then this complete femmeto part, and then we started with the phacoemulsification, removal of the capsule. Of course, phacoemulsification not difficult, but this is a RK patient where usually there will be residual hypermetropia most of the time. In this case also we did optical biometry and with the other this, but here what this aura suggested that power should be this is intraoperative barometry here, and it showed that 31 diopter is required, whereas optical biometry that showed about 29 diopter, so it showed extra, and this was much more accurate than the optical biometry, because otherwise we would have received about 2 diopter of the hypermetropia. It goes toward hypermetropia side, not toward the myopic side. So lens is placed, but only power, IOL power we have to. So cataract surgery in post-RK eyes can be challenging, and flex and aura helps in precise surgical planning. So in conclusion, intraoperative barometry is a newer technological advancement which is useful tool in patients with extreme of keratometry and where there is already RK or other refractive procedure done, or axial length problem, to ensure the optical visual outcome, which is optimal visual outcome in these complicated cases. Thank you very much.
Thank you so much, sir, for that very comprehensive talk on a very unique and different technology. Just that very few of us have access to such technology. Any questions, sir?
So I wanted to ask you, like, especially for post-RK eyes, the power, of course, will probably come out much better with it. What about toric calculation? Because, RK eyes are very challenging for if you have to put a toric, it's very difficult to measure. So is Aura a good tool for post-RK eyes for toric IOL implantation as well?
Yeah, we do in many of the patient, because here in this case, only few radial incision were there. But if there are 16 or more than 16, then there is a confusion. But if it is specifically say 8 incision, 4 incision or 12 incision, definitely we can go for even toric IOL implantation in these cases. Advantage of this technique is in a selective cases where we have already done biometry using the other IOL master and other of the biometric devices, as Dr.Sri discussed. But then we compare that how much will be the difference. In RK patient, usually it will come much more, say in 29 diopter it was by optical, but by intraoperative barometry it was 31 diopter. So we would have received a hypermetropia of 2 diopter. There were some advantages, but there are some problems also, that if there are corneal opacity, low tension and fixation problem. Although I have done in pediatric also, you have to fix it.
One practical challenge with torics will be having a library of torics for all powers, sir. So with spherical, we can still have a library, but with torics, it will be a challenge. Up next, we have Dr. Supriya Sri Ganesh, who's going to be talking on mastering toric IOL calculations and managing post-operative refractive surprises. We all look forward to hearing from her.
Good evening, everyone. I know everyone is tired. It's the end of the day. I'll keep it short. This is an important topic that I'm presenting on behalf of Dr. Sri Ganesh, mastering toric IOL implantation. So the main pain points for an implantation of a toric lens is, first of all, biometric formulae, which has been discussed, marking of the axis to use ink, physical marking, or a markerless system, implantation and alignment of the actual IOL, implantation of these toric lenses in small pupil where you can't see the toric markings in the periphery, and post-operative rotational stability of the lens itself. So coming to the biometric formulae, it's very important to consider posterior corneal astigmatism in toric implantations. Dr. Shreyas has already spoken about the total keratometry which is considered. We use the Barrett TK toric formula in the IOL Master 700 for accurate measurements for toric lenses. Now coming to marking of the axis, we have markerless systems. Of course, marking of the axis when it's done manually, when it's done accurately, it can give as good results as markerless systems. But the problem with manual marking is that there is ink. The ink spreads sometimes when there's fluid or viscoelastic, and this can actually make your axis off almost by 3 to 4 degrees. So the markerless systems are very convenient, even workflow wise and patient comfort wise. We have the Killisto from Zeiss and the IntelliAxis from Lens AR. So basically, the Killisto from Zeiss is a markerless overlay system. The IntelliAxis is on the femto platform where nubs are made on the capsulotomy which allow you to align the toric lens. So this is just a small video of the IntelliAxis. This is actually connected to the pentacam. So any of these markerless systems either take the limbal blood vessels into consideration or they take the iris pattern registration. So this is a small video of implantation of the toric lens, after which the Killisto has been put on. And as you can see, this is a femto case. You can see those nubs on which the lens is being aligned. The implantation of toric lenses is generally done under saline for better rotational stability. The advantage of the IntelliAxis is that even post-operatively, when you dilate the pupil, you can very easily see that the toric lens is on the intended axis without doing any additional measurements. Also, in cases where there is subconjunctival hemorrhage, etc., it's very useful where the limbal vessels are not captured. Coming to implantation under BSS, again, it's a very useful tool for alignment of the toric lens and rotational stability post-operatively. And generally, we leave the eye a little soft after the implantation. I'm going to skip ahead in this video and just show you the last part where leaving the eye soft makes a big difference. So here you see that the eye is being decompressed slightly, very slightly, and you see a line on the PC. This tells you that the eye is left a little soft and the IOL back contact is good. So post-op rotational stability is better if you leave the eye a little softer. It doesn't inflate the bag and rotate in the bag. A study was done again to evaluate and compare rotational stability when implanted under BSS and versus OVD. 100 eyes of 100 patients were taken and they were observed for 1 year. You can see that the rotational stability is overall much better in the BSS group. Now coming to implantation of toric lenses in small pupils. This is a device which has been developed by Dr. Ganesh. It's called the Ganesh Toric IOL Marker. This is available with Epsilon. Before implantation, you can just press this device on the lens. It creates a temporary indentation in the center and the toric marks on either side are visualized through these holes. So that temporary toric mark, which goes away after implantation of the lens, stays in the center so that you know the axis even in small pupils. So I'm just going to skip ahead in the video. The loading is absolutely the same, and after implantation you can see even if the pupil comes down and you can't see the peripheral markings, it's very easy to make out that indentation in the center, which can be then aligned with the markerless system, which is the Callisto in this case. So you can see that indentation very clearly on retroillumination, you can see on coaxial illumination. It's very easy to see that indentation, which then disappears after a few minutes after IOL implantation. This is the post-op eye trace, which shows 0-degree rotation. Now again, this is another lens. Anterior capsule fixated lenses are now becoming very popular in the toric models because they are fixed to the anterior capsule and the rotation of these lenses are minimal. This is a swivel haptic lens which is designed by Dr. Ganesh again. This lens has 2 additional haptics which pivot over, which swivel over a pivot, and after injecting the lens they can be opened up on top of the capsulorhexis under the iris. It can easily be done. And it's easy to go under the lens also with your IA probe and evacuate all the viscoelastic. So the lens is very stable, it does not budge, there's no chance of rotation of the lens. And as you can see, it's a very stable post-op refraction. So these were some of the tips and tricks in implantation of toric lenses. I'll quickly cover the next talk as well, which is managing post-op refractive surprises. This is again very important in giving your cataract patients 6/6 vision. So first you need to know why there is a refractive surprise. Sorry, just going into the slideshow there. Yeah. So first you need to go back and check why you've had the post-op refractive surprise. So recheck the biometry and see if you have used the correct IOL formulae. Make sure that you correct all cylinders either by a toric lens or by limbal relaxing incisions. Make sure that it's the right patient in the right eye. These errors can happen. Human errors, data entry errors, transcription errors can occur. Make sure that this hasn't happened. For the possible causes for minus residual refractive errors are adjustments for sulcus IOLs. If you've placed the lens in the sulcus and not made an adjustment for the lens power, this can happen. Bag distension syndrome, where the IOL is rotated in the bag or it sits a little anteriorly in the bag. Capsular contraction syndrome, all of these cause minus residual refractive errors, and the plus errors are mainly post-refractive surgery and are more common with plate haptic lenses. So this was already discussed by Dr. Gaurav. I'm going to skip this slide. So what are the management options for post-op refractive error? There's a non-surgical management. Yes, you can always give your patient spectacles or contact lenses, but the reason they've come to you is because they want to be spectacle-free after your cataract surgery. So your surgical options can either be cornea-based or lens-based. Cornea-based, of course, PRK, LASIK, SMILE. You can do an ablation or a lenticule procedure and remove the residual refractive error from the cornea. Of course, we need to wait for 3 months before we do these procedures. Lens-based options are if there is a rotated toric IOL, re-rotation of that IOL itself corrects the cylinder. Piggyback IOLs on top of the primary IOL is an option. Piggyback ICL on top of the primary IOL, IOL exchange, and optic capture, which we'll discuss. So coming to cornea-based procedures, this is the choice when the residual refractive error is less than 2 diopters. There's no corneal pathology or significant dry eye, no glare, halos, other photic phenomenon. And how long do you wait? For PRK, once the manifest refraction is stable. For LASIK, at least 3 months after the initial surgery until the refraction stabilizes. Now coming to the lens-based procedures, the eye trace has a very nifty tool which tells you how much the rotation has, how much of the rotation of the toric IOL has happened, and here it tells you how much rotation and how much change in cylindrical power will occur when you rotate it by 19 degrees. So this is an easy tool. Of course, you can always check on your slit lamp itself the intended axis and see if there's a gross rotation. Now coming to secondary piggyback lenses. When you decide to implant a piggyback, of course, implanting a piggyback lens is much easier than explanting the IOL and re-implantation of a new IOL, especially when the cataract surgery has been done a few years back, or more than 6 months, when the capsule has become adherent to the bag. Now this is an axial length independent calculation. It's based on careful manifest refraction, and For hyperopic errors up to 7 diopters, the spherical equivalent is multiplied by 1.5, and for hyperopic errors beyond 7 diopters, Holiday R formula or refractive divergence formula can be used. Now, this is just a way to calculate the power of your piggyback lens. So, it's not an axial length based calculation. So, for hyperopes, for short eyes, these are the formulae. I won't go into the details. This is the slide for, again, for hyperopes and myopes, that is overpowered pseudophakic or underpowered pseudophakic, the calculation is slightly different. Now, coming to which lens to use, of course, Rayner has their Sulcoflex lens, which is especially designed to be used as a piggyback lens. 3P silicone IOLs can also be used, or the Star ICL can also be used as a piggyback lens. Coming to the Sulcoflex lens, is a single piece hydrophilic acrylic IOL with a 6.5 mm optic and 13.5 mm overall length. It has a round edge and concave posterior surface, convex anterior surface, and the thickness is of the optic is about 0.25 to 0.75 mm. It has an angulation to sit nicely in the sulcus. So the haptic optic has an angulation to fit into the sulcus of about 10 degrees. Now, of course, polypseudophakia does have its own complications. You can have pigment dispersion, pigment between the IOLs, iris transillumination defects, uveitis, secondary glaucoma, etc. And these are the stages of the interlenticular opacification. Now, I just want to show a couple of cases where postoperative refractive surprises were managed. This is one of the first cases. Here, you can see that there is quite a bit of adhesions and fibrosis between the lenses. This is a post-RK case after which there was a residual refractive error. Here what the surgeon is doing is making a posterior capsulotomy for the posterior capsular opacification, after which a Rayner Sulcoflex lens is implanted in the eye. So this patient had undergone RK in both eyes, after which the IOL was implanted and had a PCO as well. Now, in this patient, actually a mini monovision effect was achieved just by implanting the Sulcoflex lenses as a piggyback lens. Peripheral iridotomy was done, and this is how the lenses sit in a piggyback situation. This is an OCT, and post-operatively you can see that the right eye had better near vision and the left eye had better distance vision, and the patient binocularly was seeing 6/6 and N6, which is an excellent result for a post-RK eye with a piggyback lens. Coming to IOL exchange, just a couple of videos. There are a few ways to do an IOL exchange. Again, this was a young patient implanted with a trifocal lens, which they were extremely unhappy with due to a lot of dysphotopsia. So it was decided to explant the lens and implant another lens in its place, another trifocal lens in its place. So this set of instruments is very useful. It's the grasping forceps and the IOL cutting forceps available with MST. So it's cut 3/4 of the way, and the incision is extended a little bit. One half of the IOL is pulled out of the incision and rotated out so that the entire lens comes out easily. This is the standard technique that we use. Of course, it's important to have the right set of instruments. This set of MST forceps really helps with this IOL implantation. LRIs were also done with femto to get a good result. Now, coming to explantation of plate haptic lenses, this is slightly different. Then I'm just going to fast forward this video. You can see that the lens kept rotating in the bag. So this is a high myope with a plate haptic lens in the bag. Rotation was done multiple times. You can see the IntelliAxis nubs there, and the IOL is just not sitting in place. It keeps rotating, and this lens was cut in half and explanted because it's easier to explant the plate haptic lenses this way. The same set of MST instruments were used to do this explantation. The IOL needs to be grasped tightly, and it's important to inject viscoelastic under the IOL so that you don't touch the posterior capsule while cutting the lens. This lens, a bimanual technique was used to remove this lens, and another trifocal lens was implanted. A C-loop haptic trifocal lens was implanted in its place. moving on to the next case. I'm just going to fast forward this video for the paucity of time. It's very important when there's adhesions to use a thin iris repositor to actually dissect out all the adhesions, remove the lens, and again, like I said, you can bisect the IOL completely and remove one half after the other through the incision. And here you can see what happens while removing one half, that there is a pull and a tug on the capsule, and there's a ZD there. This is a Nightingale polisher which is used to polish the PC and clean off all the PCO there. And a CTR is used. So it can be quite tricky once the bag collapses on the lens and adheres to the lens. So this is a bimanual technique of CTR insertion. And once the lens is implanted after this, you can see that it's well centered. The last case that I'd like to show is a case scenario of a 54-year-old female ophthalmologist who came for an opinion for refractive correction. She had a -6 in the right eye, -7, both eyes with a cylinder. You can see here that she's unsuitable for refractive surgery because the cornea was very borderline, and the anterior chamber depth was also 2.32, so she was unsuitable for a toric ICL. So the surgical plan was to do a femto-assisted refractive lens exchange for this patient with implantation of a trifocal lens and arcuate incisions. So 3 weeks post-op, she came back with a residual refraction, and she had a -1 residue in the right eye, and with both eyes 0.5 cylinder. So you can see that the lens here is sitting quite anteriorly, and this was how it was managed. So the same old incision was opened up, after which the IOL was moved, and here you see that the adhesions are very carefully dissected using a visco dissection technique. And the IOL is slowly lifted up. A side port incision is made, and using a cystitome, a posterior capsulorhexis is made under the IOL. So after making the initial nick, sodium hyaluronate is injected to push down the vitreous. And you can see here very carefully a posterior capsulotomy being done using a microrhexis forceps. The reason the posterior capsulotomy is being done is to try and capture the IOL in the posterior capsulotomy and push it backwards so that it negates the myopia. So I'm just showing you how that optic capture was done. It's pushed into that posterior capsulorhexis, and the lens is stable and well centered. The viscoelastic is removed, and this is the post-op image. Post-operatively, she had 6x6 parts. The lens is stable and well centered in the right eye, and in the left eye it was the same residual refractive error. So a 0.5 cylinder is still manageable, and the patient was very happy post-operatively, and this was the clinical picture. So this was a very unusual management of a residual refractive error. And just some take-home messages: prevention of a residual refractive error is key. Please communicate with the patient and have an algorithm for management. Unconventional options can work very well too. Thank you very much.
Thank you, Dr. Supriya, for two extensive talks. And I think while Dr. Sheetal is just getting set up, why not bioptics? Why the posterior capture for that patient? Just to show a different technique, or is there any additional purpose that you feel that is?
Bioptics was not possible because this patient was not suitable for either an ICL or a corneal refractive surgery. Patient had a very borderline cornea, and the AC depth was 2.32, so we couldn't even put an ICL or any other lens there. So this was an unconventional way to manage it. It was carefully done, probably not very predictable, not a very predictable way to do it. Patient was very clearly explained the surgical plan as well, because she was an ophthalmologist herself. So she was ready for it and it was done. The next speaker is Dr. Sheetal Brar. She's a senior cataract and refractive surgeon. She was with us as a senior consultant at Netradama, and now she's practicing in Brar Eye Hospital, Batinda, Punjab. Over to you, Dr. Sheetal.
Thank you, Dr. Supriya, and I would like to thank you and Dr. Sri Ganesh for again having me in this super hit course that he has been running now since the past 7 or 8 years. So it's an honor to be speaking in his course as always. So my topic today will be post-refractive surgery IOL power calculation, which was considered as a daunting task till few years ago, but nowadays because of the availability of a lot of online calculators, this seems to be not so difficult. So what are the 3 types of errors that can cause problems in IOL calculation post LASIK? It could be an instrument error, refractive index error, or the formula error. Instrument error essentially is when you use the keratometers for measurement of the corneal power, wherein they actually cannot correctly measure the corneal power post refractive surgery because the cornea has been modified, and they do not measure the central cornea, which has become flat now, and they measure the paracentral points at 3.2 mm zone, and so central data is extrapolated. So this is not very accurate, and this leads to an overestimation of corneal power and eventually a hyperopic shift. Refractive index error is again because most of the keratometers and topographers, they only measure anterior surface of the cornea, and then they convert this to the radius of curvature, which is measured to diopters using this formula, wherein the refractive index of cornea is assumed to be a fixed one, assuming the fixed relation of anterior and posterior curvature, which actually is not. So since they use this fixed refractive index of 1.337, which actually later was found as 1.334, and it can actually vary depending upon the air and cornea interface and cornea and aqueous interface. So this also can lead to errors in IOL power calculation post LASIK. Now the third one is formula error. We all know that IOL calculation depends on effective lens position. Now following LASIK, the corneal curvature changes and ELP is wrongly estimated. So most of the third generation formula that we are using today will estimate the position of the lens more anteriorly, resulting in calculation of a lower powered IOL, and thus finally a hyperopic surprise. And 1 mm error in effective lens position can actually result into 1.5 diopter change in the final refraction. Now coming to different methods how to obtain true corneal power after refractive surgery, there are a lot of methods, and many of these are now obsolete. They are just of historical importance. So the formulae which earlier we were using were clinical history method, contact lens over refraction method, topography based formulae, central ring topography method, net corneal power method. So all of these were being used. For the want of time, I will not go into details of these formulae, but by and large now these formulae we are not really using. Topographic based formulae such as Koch and Wang formula and Sharma's formula are still being used in the ASCRS online calculator, and they are regression based formulae based on the LASIK data but not really suitable for post RK eyes. Central ring topography method is one of the methods that can accurately predict post RK the formula, the IOL power calculation in RK eyes. Now double K formula by Arambury is again one of the popular formula that actually uses the post-refractive surgery corneal power for calculation of the vergence or the IOL power, and the pre-operative surgery corneal power for ELP prediction. And for the current 3 generation formulae, it offers a kind of adjustment, and this can actually be done using this website drhill.com, wherein you can go and use the correction table for each of these formulae. So there are other formulas also. Hagee's L is a popular formula which is part of the inbuilt software in IOL Master 700, and 500 as well. So this is again a regression based formula based on the statistics of post-LASIK eyes. The accuracy of this formula may actually decrease if the eye is on the edge. So it is quite popular formula, but for very highly myopic, hyperopic eyes, post-LASIK it may not be very accurate, and also not accurate for post-RK. Muscat formula is again a formula which is currently being used at some places, and it basically adjusts the power of the IOL using post-op measured data, and you have to have the knowledge of the surgically induced refractive change as well. Now our life is made much easier by the use of these, by the availability of these online IOL calculators, which are very easy, handy, and fairly predictable also. So there are various calculators which are available online on the ASCRS website, the post-LVC IOL calculator, the Hoffer program, as well as the Dr. Hill calculator on the Dr. Hill website. And this is a screenshot from the ASCRS website, wherein it's quite convenient to use. So you just need to enter the pre-op LASIK data if it is available. Even if it's not available, you can just put in all the ultrasound biometry data which is there in the lower part. And if you have a topographer, then it incorporates various topographers as well, such as TOMI, Galilee, ISIS, Atlas, and Pentacam. And you can use their specific values, and this can also, the topography based formulas can also be used. And once you have put in all the data which is available to you, it, depending upon what is available, it will automatically give you the IOL power which is feasible with the formulae which are incorporated in this. So this is again very popular, Barrett-Truquet formula. Most of us are using this because this is online, available free. And this is based on the Barrett Universal 2 formula that uses a modified keratometry value for post-refractive surgery eyes, and it also provides a double K solution when central Ks have been altered. Holiday EKR formula is again another formula which is quite accurate. And in this, you basically use the EKR values from the central 4.5 millimeter zone in the EKR map and use these K values in the Holiday 2 formula. Total keratometry, I will not go into details, Dr. Shreyas has already covered it, but essentially the swept source biometry and a combination of the telecentric keratometry, it basically measures the actual curvature of the anterior and posterior cornea, and it provides us the real values of the curvature of the anterior and posterior surface of the cornea, and thus it is now considered as most accurate out of all corneal measurements obtained through different methods. So these are some results with the Barrett-Truquet formula. And now we also have ray tracing formulae which are available in certain advanced equipment such as MS39, wherein the keratometry is quite accurate because it's ray tracing, and you just need to enter the axial length values, and it will give you the power calculation. So just discussing one case briefly. So this is a post-myopic smile patient who had come to Netradhama 4 or 5 years ago, and basically the patient's refraction was -6.5 and 5 in the right and the left eye respectively. He presented with the grade 2 cataract. So this is the topography of the right eye, and you can see there is still some amount of flattening which can be seen, and it is well centered. And if you look at the EKR map, you see it is not very regular. It's not a single peak. What you want to see here is a single peak that signifies a uniform distribution of keratometry. So since it was not a single peak, and when we also saw that the corneal abrasions were on the higher side, 0.65, and the Z4 was 0. So then we thought, why not use a negative aspheric lens such as Zeiss City Lucia that actually can result in slight negative asphericity post-surgery. So the patient also achieved some amount of depth. So City Lucia calculations were performed using different formulae, and you can see that we use the ray tracing method, the Hagees L, Holiday 2 with EKR, Barrett-Truquet, and Barrett-Truquet TK. So finally, you can see that the Barrett-Truquet and Truquet TK are very close, and also the Holiday 2 EKR. So this is what we went ahead with. And finally, what we saw at post-op 4 weeks, the correction was quite good. The spherical equivalent was within 0.25, so this is an excellent result for a post-LASIK case. So in conclusion, in post-refractive surgery, eyes use more than one method to measure central corneal power, use more than one formula, and it's always better to hedge in the direction of myopic results, especially if it's a myopic LASIK, and total keratometry based formulas which are now being increasingly used are give most accurate results, and patients should still be warned about potential need of refractive correction after cataract surgery. So pre-op counseling and chair time still remains the cornerstone of for success in these cases. Thank you so much for your attention.
Thank you, Dr. Sheetal. With that, we end this session. Thank you all for being here. Thank you once again to all the speakers, and see you at the next AIOC. Thank you very much.